So our next guest is Dr. John Kanitra. I hope I'm saying that right. Dr. Kanitra is a senior surgical resident at Ascension Health, Ascension St. John. And he is going to talk to us today about hyperperfusion syndrome after CEA. Dr. Kanitra, you have the virtual floor.
Perfect, thank you. Can you hear me all right?
Yes, thank you. And welcome.
Apologize for arriving late. I just scrubbed out. So I'm John Kanitra. Thanks for the introduction, Rebecca. So I'm a fourth-year general surgery resident. I was given a talk about hyperperfusion syndrome after carotid endarterectomy. So this will be a pretty brief presentation. My main objective is just so that the audience kind of has an understanding of what that means. What is hyperperfusion syndrome? How do you identify it? And how do you manage it? And also, I guess, why it occurs. So, let's see. So just so everyone's on the same page, because there's a variety of training backgrounds here. So for basic anatomy, you have your main blood flow to your brain is from your common carotid artery. This bifurcates into your external artery and your internal carotid artery. And then, of course, it goes up to your brain. So at that bifurcation, because of the bifurcation, you have turbulent blood flow, and this is where we tend to see most atherosclerotic disease or plaque. So this is your internal carotid here, and this is an example here where you might see plaque, and this is the basis behind carotid stenosis disease. So how do you intervene on this? There's three main options, there's three options to intervene on carotid stenosis. So CEA, which is carotid endarterectomy, CAS, which is carotid artery stenting, and TCAR, which is a newer, as of 2012, transcarotid arterial revascularization. Just very briefly, just so we're all, again, on the same page. As far as carotid endarterectomy, in general, this is the gold standard as far as what should be done. This is an open surgical procedure, so there's an incision over the neck. We actually dissect down to the artery, make an anterior arteriotomy, and you remove the plaque manually and then close with usually a patch, like a bovine pericardial patch, and you close the patient. A carotid artery stent, this is usually done from a transfemoral route. So this is the interventionalist will access the femoral, usually the common femoral artery, and go up endovascularly and deploy a stent into your internal carotid artery and your common carotid. This is done in basically high-risk patients who, for whatever reason, have a contraindication to open surgery. So, as you might expect, one of the outcomes that most databases look at are the stroke rate and myocardial infarction rate after these interventions. So your stroke rate's actually higher with the carotid artery stent than open surgery, but your myocardial infarction rate is lower, and again, that's just because it's not a surgical procedure. TCAR is kind of a hybrid approach between the two. So you do a smaller transverse incision over the common carotid artery, and then you access it with a needle and a sheath, and the remainder of the procedure is done endovascularly. The only difference between this and a carotid artery stent, it's actually the same stent that's deployed. But as you see at the top here, this device is a flow reversal, so it actually connects into and we access a femoral vein. So this is a high pressure system going into a venous system, so it reverses the blood flow before you put a wire or anything past your diseased area, and then you deploy your stent. So if this shears off any plaque, theoretically it should go into your device, and there's a filter that filters it out before it goes back into the femoral vein. So this is different than this has a lower stroke rate, as you might imagine, than a carotid artery stent, which is you actually have to deploy this catheter or wire past your disease segment before you deploy your filter. So that, as you're passing the wire, subjects possible breaking off plaque. So let me go to the next slide. So, sorry, there's a little delay on my end. So what is cerebral hyperperfusion? Just from a very basic standpoint, once you correct the carotid stenosis, so for example, you do a carotid endarterectomy, as you might expect, you're going to have a sudden increase in blood flow to the brain. So this increased flow will lead to an increase in your intravascular pressure, which of course will cause a higher hydrostatic pressure, forcing fluid out of your vasculature into your brain, and this can cause cerebral edema, and then this leads to your symptoms of hyperperfusion. So why does it occur? So your brain has a capacity to auto-regulate its intracerebral blood flow. So, and this is why, one of the most common things in school I'll talk about is your CO2. So if you have low CO2, this will actually cause in your blood. This will actually cause your intracerebral vessels to vasoconstrict, and vice versa. So if you have patients with carotid stenosis, they have of course lower blood flow, so your brain compensates by vasodilating. So once you revascularize, for whatever reason, this mechanism isn't completely understood. But for whatever reason, there's a delay in this autoregulatory response. So once you revascularize and you have an increased blood flow, the brain, there's a delayed response, so it continues to be vasodilated. So of course, you're increasing your blood flow into a dilated vasculature. Also, the patients who tend to have this syndrome have hypertension at baseline. So as I kind of explained earlier, this causes your hydrostatic pressure gradient. So by having high blood pressure and inability you're at a persistent vasodilatory state, this causes a high intravascular hydrostatic pressure, which forces essentially fluid into this interstitial space, so causing cerebral edema. So what are your signs? Well, the first and most common sign is headache, and this, or most, I should say, I don't want to say pathognomonic sign, but the first sign you would see in patients is a headache, and it's usually an ipsilateral headache. But interestingly, I put this in here. Some of the studies and systematic reviews I went through did show that some, up to even 2/3 of patients don't have a headache. But that would be your more severe symptoms would, of course, heighten your suspicion earlier. But usually a headache, this is just something to have in the back of your mind to make sure to rule this out. So more obvious would be if you actually have a focal neurologic deficit, a nausea of decreased mentation, or all the way to loss of consciousness. So if it's not controlled or caught at this stage, this can lead to seizures and eventually even a hemorrhagic stroke. So this can occur, your window for when this can occur is within 2 weeks following surgery. Interestingly, the incidence seems to peak about 12 hours after a carotid artery stent and about 6 days after carotid endarterectomy. So that's why this is important to know, because this can actually occur after discharge. So just general epidemiology, it's seen in about 1 to 3% of patients. High risk are folks who have high-grade stenosis, so greater than 80% stenosis, especially if they have contralateral stenosis, because now your brain's not dependent on collateral flow since you have bilateral stenosis. So essentially your entire cerebral vasculature is vasodilated. And as I mentioned, if they have high blood pressure at baseline. So how do you manage this? Well, as you might imagine, initial control is just blood pressure control. So once, if you have a patient who starts complaining of a headache, now you want strict blood pressure control to under 140/80. So if they continue to have symptoms or they worsen, or especially if it's any of the harder symptoms such as a focal neurologic deficit, loss of consciousness, you need to do a CT scan to rule out a hemorrhagic stroke. So how do you prevent this? Really, the best method is just perioperative blood pressure control. So less than 150 is a general recommendation. And this is why these patients are kept overnight in the hospital, because after you're intervening on the carotid bulb, there can be some labile blood pressures, high or low. And most of that resolves within 24 hours. There has been studies on as far as, other predictive methods by looking at, transcranial Dopplers or CT perfusion studies, but there's no general recommendation for that, and that seems to be mostly just in the research phase still. So really, the take home is just blood pressure control. So why is this important? Well, as you might imagine, this can increase your morbidity and mortality rate in these patients, increasing your length of stay, and this can occur following discharge. So, if their primary provider needs to be able to pick up on this. So if a patient comes in or calls their primary saying, hey, I'm having a headache, this is important, or just for any provider for that matter. So a nurse or anyone, this is important for them to pick up on this. Or in the hospital to let a provider or somebody know, hey, the patient's complaining of a headache, as opposed to just giving him a pain medication and seeing if it resolves. And these are my references. Thank you for your time. And again, I apologize for being late, but appreciate you letting me talk at this meeting.
Well, thank you, Dr. Kanitra. You weren't late. You were just right on time for your presentation. And yeah, I didn't know that hyperperfusion syndrome could be, um, occur after discharge. So that's really helpful to know. It looks like Amy did ask a question in the chat, and then I have a question for you also. The question is, what are the stroke rates of TCAR? Is this higher or lower than carotid endarterectomy?
So I don't have the numbers right off the top of my head. I believe it's 2 to 3%, or it depends. There's a lot of different trials on it. Roadster trial is the main trial on it. But no, in general, it is higher than carotid endarterectomy. So carotid endarterectomy has the lowest stroke rate. And I'm sorry, was there a second question?
Yeah, my question is more of documentation. So say the patient's discharged and maybe a couple days later they come to the ER and the ER doctor doesn't diagnose them with hyperperfusion syndrome, but their documentation describes hyperperfusion syndrome. So what kind of documentation would you see from like a provider who's describing hyperperfusion syndrome but not actually diagnosing it, if that makes sense?
Yeah, exactly. So if you're like doing a chart review or something, you're wondering if the patient has, I think the first thing would just be time frame. Is this all patients presenting back 3 days post-op carotid endarterectomy with a headache? Their initial, usually in triage, you'll have a blood pressure. So maybe their initial blood pressure is 160, 170, something higher. I think that alone would be enough to diagnose it because it is a clinical diagnosis. There's not really an imaging or your imaging is to kind of catch the sequela or to rule out a hemorrhagic stroke. But the actual diagnosis is clinical. So basically, if you have high blood pressure, document high blood pressure and a headache, would post-operatively a carotid intervention, that would be enough to diagnose it.
And if somebody
within 2 weeks.
Within 2 weeks.
Sorry.
So say somebody is having this, and would the CT scan show anything or not really? I mean,
no,
if they weren't
it
having a
shouldn't.
stroke.
If it does, it's correct. Yep, your CT is to rule out a stroke. So
Okay.
it should not, the syndrome itself, hyperperfusion syndrome, does not have any imaging findings.
Okay.
So like I said, there are some, in the literature, there are, some centers studying other imaging modalities such as CT perfusion scans and transcranial Doppler, but that's not really a standard yet, and that's very much still in the investigational phase. So in general, no, there's no imaging findings to diagnosis. It's a clinical diagnosis. Your imaging is to rule out a complication of the syndrome.
Okay, good to know. Thank you so much for clarifying. I see some
absolutely.
Comments in the chat. I just want to see if we have any more questions. So our group is saying great information, very helpful. As you know, I get a lot of questions about, or not a lot, but I mean, hyperperfusion syndrome is an FAQ. So now we know. Now we know that.
No, this is
it's
not, like I said, it's on 1 to 3% of patients, and I think most commonly what happens, because even when I made this presentation, I was just kind of talking with some of our junior residents about it, and even then they didn't, they didn't know any of this. Like, how do you identify it? What is cerebral hyperperfusion syndrome? So, I think this is good just for everyone to be able to identify and know. I think more commonly what happens, and is somebody's complaining of a headache and they get whatever medications ordered, their Norcor or their Tylenol, and they feel a little bit better. But this really underscores, or our junior residents know that, hey, we got to control. We have to have strict blood pressure control in these patients, but they might not really understand the rationale behind it. So this is why.
And you said some of the symptoms are headache and focal neurological deficit. Is there one common focal neurological deficit for this syndrome, or not really?
No, that basically your stroke pathway. So it'd be ipsilateral, so you would kind of go, it basically would present like a stroke, but that would be pretty easy to identify, because at that point you'd be, depending where you're at, would activate your stroke team and they'd be getting imaged regardless. So.
Okay. And so the deficits,
but no, there's not.
The deficits would be on the same side as the carotid procedure.
The contralateral side. So You would be
Okay.
having, if you have your right carotid, we do an intervention on the right carotid, and you have cerebral hyperperfusion, which causes, let's say, those focal neurologic deficits or even a stroke. That would be a right-sided stroke, so you would have left-sided symptoms.
Okay.
So your
All right.
neurologic deficits would be on your left side.
Okay. Thanks for the clarification.